Hi, my name is Marie Manassian, and I'll be discussing reforming current urinary catheter procedures to cut down or eliminate CAUTI, which stands for catheter-acquired urinary tract infections. Let's identify the problem. So currently, nurses and other medical professionals place an indwelling urinary catheter in most patients transferred from the ER to the hospital, even with those patients that don't necessarily need one. Consequently, urinary tract infections are more prevalent with roughly 75% associated infections due to inserting an IDC. Taking it further, the CDC writes that patients with an indwelling IDC are 3 to 7% more likely to develop a catheter-associated urinary tract infection. The plan to limit who receives an IDC would likely prove successful for several reasons. The most substantial, of course, is that not all patients need one. It'll also cut down on CAUTI and other medical complications such as prostatitis, cystitis, endocarditis, and septic arthritis, just to name a few. So to realize the necessary change, it is important to educate all medical professionals about the problem that arises with IDC overuse and advocate larger policy changes, especially at major medical institutions that definitely overuse IDCs. And of course, with anything regarding change, there's going to be resistance and an unwillingness to accept those new practices because maybe these practitioners will believe that not administering indwelling IDCs to the patients will elicit medical problems greater than those that emerge with overuse. What's the significance of the problem? Well, underlying the significance of the problem are the medical complications that occur with indwelling IDC overuse, both in relation to UTIs and other medical complications. Green notes that 3 million IDCs were administered each year, and 65% of those were not needed or appropriate. So finally, CAUTI is responsible for nearly 13,000 deaths a year, and this problem increases hospitalization stays to an extra 2 to 4 days on average and adds between $1,200 to $2,400 in medical expenses. So for my change theory, I chose to incorporate Lewin's 3-stage model of change throughout my project. His model incorporates 3 phases, which are the unfreeze phase, change phase, and the refreeze phase. And it's pretty straightforward. The way it works in this particular case, we would unfreeze the current IDC procedures, which would allow for relevant stakeholders to take a really close look at how they're doing things, what the policies are and the procedures. By doing this, they'll be able to establish what the shortcomings are. Once they realize what their shortcomings are, they start to create change. That's where the second stage comes in, and they start implementing new policies, new procedures, and new ways of doing things. That is the change phase. Lastly, we go into the refreeze stage, which allows for the new status quo to be solidified. So given how prevalent IDC procedures are in hospitals around the country, I believe that Lewin's change model will likely prove useful, enabling stakeholders to recognize that it's not worth maintaining the old ways that are not working and increasing CAUTI, and that feasible alternatives do exist. This brings us to the EBP project question. In patients transferred from the ER to the general hospital, what practices can medical professionals adopt compared to current ones to limit IDC use to reduce CAUTI within the next year? Literature review. So some of the databases that I used and I found relevant and applicable to this project were PubMed, Medline, Scopus, Science Direct, and some of the keywords that I used in combination or separately were catheter overuse, UTI, CAUTI, urinary complications. Summary of evidence. As mentioned, I used Lewin's changed model, and as we go along with these slides, I will incorporate that throughout my project. But let's go ahead and consider the evidence related to current practices. So the evidence points to the overuse of IDC and the associated increase in CAUTI. In 2018, Green did a study. He examined 18 hospitals, and he had 2 groups of patients. The first was 13,215 patients, in which 899 did have catheters, and the other group was 12,104 patients, of which 718 also did. So the results did indicate that professionals were overusing IDCs. But the great thing was, after they implemented institutional guidelines, they saw a reduction of new catheter placement of nearly 4%. Mays also did a study in 2022, and he concluded something similar, noting that the IDC use declined from 1.6 to 6%. He said that the decline was due to the incredible expense associated with COTI, which was nearly 864 million. Parker did a study as well, which was a little different, but his purpose was basically to check into 4 Australian hospitals and see how staff would respond and be compliant to change. He wanted to see if things were new policies and procedures were implemented, how the staff would respond. So although these scholars employed different methodologies and they had different aims and objectives governing their scholarships, they all nevertheless concluded that reducing IDC use reduces COTI and other health complications. Recommended best practice. So in my opinion, I believe in any profession or group of networking professionals, in order to get the best consistent practice, would be to have a central place to look at, that everybody can follow the same exact guidelines and practices. And based on evidence, the best practice involves implementing a broader framework. In this case, we would look at the CDC, which is the nation's foremost public health protection agency. So the CDC would direct, in this case, all the medical professionals on when to use IDCs and when to avoid them. So they would have basically the policies and procedures specifically on usage. And as I mentioned, that would be a recommended best practice. And although the CDC is not a regulatory agency and it doesn't really have the power to enforce its recommendations, the culture is that hospitals generally adhere to its guidelines. But for the CDC to heighten its effectiveness, it must make a concerted effort to advance its position and demonstrate its validity. So that's where they can improve. And the other good news is hospitals, they don't necessarily need to look at that to the CDC for guidelines, because they can also implement their own guidelines based on the CDC's guidelines if they want to make it more specific or pinpointed to their practices, as hospitals do have things that are a little different based on their own policies and procedures. Okay, let's talk about policy and protocol for practice change. The policy title is Reforming Current Urinary Catheter Procedures, and it would take effect October 1st of this year. The policy is as follows. All medical professionals must adhere to CDC-issued guidelines on IDC use, staying current and up to date in an effort to reduce their frequency and mitigate the risk of COTI and associated health complications. I have my procedures and their rationales next to them. There's 3. So let's start with the first one. To develop effective evidence-based guidelines regarding IDC use. And what this would do, these guidelines would help ensure that hospitals follow similar procedures across the board. So there would be a streamlined procedure. Number 2, use programs like MessageWorks that the CDC uses, but any communication program would work. And this would to communicate any updates or policy changes within that hospital. And this would allow for clear and consistent communication, which would leave the medical staff knowledgeable and feeling supported. And also, it would help eliminate mistakes, because as we know in the medical field, clear, concise, and consistent communication is very important. And number 3, to engage in continual periodic follow-up. This would enable effective policy implementation in the event that anything changes. Again, the medical field is constantly changing with new policies, procedures to make things more effective, and also technology is always changing. So we would need to periodically follow up in order to update any new policies and implement them. So in this, you can see that the policy and protocols for practice change speaks to the need for hospitals to follow CDC-issued guidelines regarding IDC use in patients that go from the ER to general hospital. The procedures relate to the CDC, while the rationale would help ensure that hospitals implement the desired change. In other words, the rationale would be useful for the second step of Lewin's change model, as it would help hospital staff understand the reasons for change and how change will look. So for my action plan, I have implemented 3 alternatives to possibly remedy the problem. In the first category of technology, I believe that hospitals can invest in antimicrobial coated catheters or catheters with reminder systems for timely removal. I think this would help tremendously, but at first, it can seem that this would be a very costly alternative. However, if you take a deeper look, dealing with CAUTI is way more expensive, and this proves to be a more effective way of mitigating CAUTI and less expensive. Number 2 would be to create a hospital board of individuals who would audit the catheter use. And this would help identify high-risk areas or ensure safety. And it would obviously work to limit infection. And the third would be to use alternative devices. And this may not work for the patients that absolutely need to be catheterized. But again, for those that don't, we can use external condom catheters or use intermittent catheterization, which may lead to fewer UTIs. So keep in mind that each of these alternative solutions have their respective strengths and their limitation when it comes to addressing this issue. So I have 6 steps to implement my plan. Number 1 would be to familiarize hospital staff with CDC guidelines, which would mean that all staff members understand the guidelines and their importance in promoting patient safety and reducing catheter-associated infection. Number 2 would be to develop hospital-specific catheterization protocols, which would align with the recommended best practices. Number 3, to provide education and training across the board. Number 4, to monitor and evaluate outcomes, which would be used to track the impact of the CDC guidelines implementations on catheter-associated infections, patient outcomes, and healthcare-associated costs, which we would use as a guide to further make improvements. Number 5 would be to foster and culture best practices and safety, and we would encourage open communication and feedback among staff members to ensure continuous learning and improvement. And number 6, we would have regular updates and revised protocols so we can have the most updated, latest evidence-based practice. So as you know, these responsibilities for plan implementation did include integrating the CDC guidelines into the hospital and developing specific protocols, providing related training, and offering necessary follow-ups and other associated information with individual steps. And these processes were very time consuming, and they did require extensive planning and collaboration between and among medical professionals, but ultimately it did prove successful, and it has since continued to contribute to a reduction in catheter use and related health complications. So the last thing that I want to say is the implementation plan would effectively amount to the change component of Lewin's model, as this is where the steps are necessary to produce improved IDC outcomes occur. As you can see, I have outlined the steps above. Once these steps are implemented, hospitals would have to engage in the refreeze process, making sure that the new status quo remains in place. Okay, let's talk about the evaluation plan. After implementation, hospitals will reduce how frequently they administer IDCs, and simultaneously they will see a decrease in the number of CAUTI. Influencing the change is the realization on part of the medical staff that the current use of IDCs led to too many CAUTIs, health problems, and unnecessary expenditure of hospital resources. And then while some medical professionals were reluctant to change, the abundance of research that testified to the benefits of doing so persuaded them to move forward. And then moving forward in the future, maybe we can have a group of identified hospital stockholders to study and research and also work in conjunction with the CDC to just come up with, better policies and implement them. And it wouldn't be such a top-down management type of approach. So lastly, I do want to also talk about Lewin's change model again and say that evaluating the change is, of course, important. And although Lewin's model ends with the refreeze stage, it might be useful for hospitals to continue to reinforce the need for change, especially in the face of any resistance. In other words, while the refreezing stage has already occurred by now, hospitals may find themselves returning to the change stage so that they can successfully move forward with the new policies in place. Here are my references, and this concludes my presentation. I hope you enjoyed. Thank you for listening.